How's it going, guys? Medium difficulty question. Hematology, step 1, internal family medicine, 2 CK. 9-year-old boy, 5-day history, blood diarrhea, fatigue, 3 days, A, febrile, sclerolicterus, pallor. Laboratories show hemoglobin, 7 grams per deciliter. It's low, should be 13 to 17.5 in males, non-menstruating women, 12 to 17.5 menstruating women. MCV normal 85, should be 80 to 100. Leukocytes elevated 19, should be 4 to 11,000. Platelets low 60,000, should be 150 to 450,000. Coombs test negative. All the Coombs test means is, do we have antibodies against RBCs, yes or no? So it's negative. What does that mean? We don't have antibodies against RBCs. Let's just hop through. Which of the following cycle explanation for these findings? Choice A, cold autoimmune hemolytic anemia, wrong fucking answer, because as I just harped on, we don't have antibodies against RBCs. Cold autoimmune hemolytic anemia refers to the formation of IgM antibodies against RBCs. You can see that with CMV infections, such as with CMV mono, with mycoplasma. Okay, so let's say 23-year-old male, bilateral interstitial infiltrates, pneumonia, low hemoglobin, Coombs test positive. That's just cold autoimmune hemolytic anemia. They can tell you a blood sample shows agglutination on the way to the laboratory, okay, because you have a decrease in the temperature of the blood in the test tube. Choice A, wrong fucking answer. Choice B, G6PD deficiency, wrong fucking answer. And you know it's wrong because your platelets are low. So you can have infections, drugs, precipitate hemolysis in the setting of G6PD deficiency, but you're not going to get thrombocytopenia. Okay, there's better answers here as we're going to hop through. But G6PD is an enzyme that leads to the production of NADPH, which is a reducing agent that normally protects RBC membranes from oxidative damage. So in the setting of a paucity/deficiency of the enzyme, we have increased proclivity for oxidative damage and intravascular hemolysis of RBCs, leading to sclerolicterus. You could get degmocytes. Okay, those are the bite cells. You get Heinz bodies. Point is, wrong fucking answer. Choice C, HUS, correct answer. So this is where you have EHEC, O157H7, C. coli, or Shigella, where you have toxin production that's going to lead to damage to the afferent arterioles going to the kidney, where platelets will plug the endothelial damage, leading to consumption and thrombocytopenia. The platelets are jutting out into the lumina of the microvasculature, leading to shearing of RBCs flying by, which is going to produce schistocytes. The combination of thrombocytopenia and schistocytosis is called MAHA, microangiopathic hemolytic anemia. So HUS is it's a triad: thrombocytopenia, schistocytosis, and renal insufficiency / hematuria. Now, we don't have the renal issues in this question, but we can eliminate to get there. Let's just hop to the others. Shigellosis, wrong fucking answer. There are some students for a curveball. As I just said, Shigella can cause HUS, but by all means, this could be EHEC, O157H7, causing the HUS here. If this were isolated shigellosis without HUS, why would we have thrombocytopenia? It doesn't make sense. So if this were just an isolated Shigella infection without HUS, there's no reason why we would have thrombocytopenia here. Choice D, wrong fucking answer. Choice E, TTP, wrong fucking answer. You know it's wrong because you're going to have fever and neurologic signs, which you don't have here. So TTP is going to be inactivation of ADAMTS13, a matrix metalloproteinase that normally breaks down von Willebrand factor multimers, very buzzy, regurgitated garbage. But TTP is a pentad, HUS is a triad. So TTP equals the HUS triad plus fever and neurologic signs. And here you can clearly see that we're afebrile, so right away we can eliminate TTP. Choice E, wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe to my channel. Appreciate your time. That's it.